Thank you very much, Dennis. Really appreciate that very interesting presentation, and it really sets the tone for the day, so thanks once again. As I mentioned earlier, we will hold questions until after the panel, and then we'll ask questions related to all the panel members and Dennis. The panel will be discussing key concepts in the areas of health literacy, cultural competency, and language access services. They'll also address things that have changed over time, as we have mentioned since we began, and facilitate integration of these areas. I will not go into a detailed bio sketch of each of the panelists. It's available in the handout materials that you have. Our first panelist is Dr. Michael Wolf, Professor of Medicine and Director of the Health Literacy and Learning Program in the Feinberg School of Medicine at Northwestern University. He is an acknowledged expert in the field of health literacy and a member of the Roundtable. Our second panelist is Guadalupe Pacheco, Jr., Founder, President, and Chief Executive Officer of Pacheco Consulting Group. He has extensive experience in the areas of health policy, cultural-centered service delivery, and public engagement. Welcome. Our third panelist is Wilma Alvarado-Little, Founder and Principal of Alvarado-Little Consulting. She's been an advocate for linguistically and culturally appropriate health services for over 25 years, and once again, a member of the Roundtable. Melissa will do us well for this. Each speaker will have 10 minutes for presentation, and Melissa will give the appropriate warnings as the speaker continues with the presentation. Michael, will you begin?
I don't know what short straw I drew to have to be the expert of health literacy on Institute of Medicine Roundtable on health literacy. I feel like the other two are going to be able to say something that is much more new and is my slide coming up, or I'm sorry, is my presentation available? Oh, there we go. Okay. Yeah. I'm trying to put thoughts to what are some key concepts to health literacy, and especially to this group. I apologize for maybe stating out the obvious, but I was trying to summarize a little bit of what I thought was maybe a flavor for what seems to be like a very natural integration for these three topics, although I think what may be more in common is a lot of the stagnation in the field, and also the challenge to get a lot of attention to all of these topics. And my first thought, which I think is probably an inappropriate analogy of thinking of these three topics, was kind of this idea that they all kind of fit within each other, and you can almost argue about the order to some regard. But I guess for the nature of this conversation, I was thinking of these really all fitting into the larger of these Russian dolls as fitting into the healthcare quality, safety, and equity umbrella, that of course all of them, and we've been trying to struggle for a while now to really get our voices heard to show how all of these issues, health literacy, cultural competency, and language access, really do matter to quality, and how do we get that. And I think Dennis's point really is a lot of maybe my one point I'm making my now 9 minutes left, that this is an issue that really requires a good business case. And this is something I heard actually asked to me several years ago at an IOM meeting by George Isham, what is the business case for health literacy and how do we make it? And it's still something that is that kind of black box. It seems obvious to some regard, but it's how do we make that? So some of the key concepts I was going to talk about with health literacy, at least the way, in my mind, how I've been able to kind of organize and think about health literacy is that for many of us in the field, I think what's new may not be new to especially those of you who are part of the IOM report back in 2004 and its building up discussions. A lot of it is what you already knew already, but it took a long time for the rest of the field and those on the periphery learning about health literacy to get beyond maybe the superficial scratchings of what this really was. So maybe it took a long time for the field to recognize what the IOM had realized at the very beginning, that it is a risk factor and an outcome. We frame it, and a lot of people have blamed maybe health literacy research in the United States as taking a very medical focus, that it's diagnosing a risk factor, a group that is vulnerable, that is going to have worse health outcomes. And I think that unfortunately it is the case that it is a group that has been kind of recognized, and a lot of the research has framed it that way, whether we want to argue if it's appropriate or not. And it has caused some division in the definition by some. But it's also an outcome. It's something that we want to promote And that, I think, is why we really have kind of two faces of health literacy. And to that regard, it's also an individual and a societal trait. And a lot of what I feel like has now become more commonplace, and again, this is something that was not new to the IOM Roundtable over a decade ago, is that everything has to come from the standpoint of complexity is framed in the context of the task. And Rima has talked much over the years about deconstructing the task. So it's not just about an individual skill set or knowledge or prior experience, but it's also beyond that. It's about health literacy really reflects, and what we now hear in Howard Koh's presentations and others, that, you know, how do you think of a health literate healthcare organization, and how are we imparting better information, how are we increasing access to services to those that we serve. It's also context dependent and modifiable, and I think it's the latter point I really wanted to comment on in what little time I have, that in many ways we framed health literacy in the context of healthcare equity and health disparities, which make it very conducive to fitting and integrating with cultural competency and language access, because what we're really trying to think about is it's something we can do something about. It feels less formidable maybe as a task to say that we can do better at communicating information, letting people understand what they have what their options may be, how to make them more informed about healthcare decisions, than maybe something that we've been struggling with for many, many decades in terms of other kind of socioeconomic factors that cause disparity. And again, the definition that was set forth years ago, again, this is not anything new. I'm just putting myself in context here. It's really an emphasis on accessing, understanding, and applying information. And that, I think, is important, because what has been a key concept for me, at least, is that it's a notion that it has been central to this set of activities, where I think also in the field right now that we've expanded and continue to expand on what the definition actually is, to the point where, is it health behavior? Is it something that maybe facilitates health behavior change? I think at some point we contextualize it and really try to say maybe what we really want to work on are interventions that at least help people become more informed about their health and how they can participate in healthcare. Again, the data is very obvious. It's strong ties to socioeconomic status, race, ethnicity, and age. It can't be unpacked very well, and that's been very, very clear in a lot of the literature, as well as we all recognize that solutions, regardless of how we view health literacy, the solutions come from the healthcare system and beyond, that it's our responsibility to simplify the task, make healthcare services more amenable to those who we serve. So on my 3 points of what's new, and I don't know if it's so much what's new, I guess it was my way of trying to jump to the chase and figure out how to best integrate these 3 topics. And health literacy has been around a long time, but cultural competency, that term has been around far longer. And what successes we've had, you know, I think are variable. But again, regardless of how we frame it in any of these 3 buckets, I kind of viewed health systems must expect and prepare for diversity. And that, to me, has, you know, we've been thinking about this for a while, that there are a few buckets that are primary that we need to think about healthcare communications. And I was appreciative for Dennis's conversation about, you know, with the Plain Writing Act. And there's many opportunities with the changes that have happened right now with health insurance coverage and the Affordable Care Act, to think through how you can actually mandate and consider that interface with every way you kind of communicate information to patients, whether it be through the web, whether it be through print materials, anything. That's just been something commonplace. But I would say the challenge has been in our field dissemination. It's like we've known for a long time what to do. We just have done a very bad job of doing it. Provider training as well. How do you engage providers? And also, how do you think about ultimately what's going to happen for many of us is that we're going to have to redesign workflow and think about, again, George Isham's favorite term is the hardwiring health literacy principles into practice. And the question I kind of pose here is that it really keeps coming back to, you know, all of these things sound great, but ultimately the question becomes is, you know, is the investment worth it? In terms of, if you were to tell a healthcare system like the one I'm at right now that has a decent payer mix, that make it very, you know, a very wealthy hospital that has resources, that isn't thinking about the safety net clinics that really have to do more with less, that you still have to make the case for them that, you know, why would you want to spend money to focus on your communications and training providers, and maybe even consider a quality indicator for how well they've spoken to patients. And I think that is one of the reasons why we haven't been able to move forward in quite a bit. The second point I was just going to really think about, that's whether, again, it's something new so much as just thinking about the integration, is that all of these topics represent vulnerable populations with known disparities, and thus ongoing assessment could be argued is warranted. That if you want to be able to see that anything we do in the future has an impact, you'd like to be able to show some sort of, closing of the gap between those with the lowest literacy skills or those who are viewed as more marginalized than another group, that you'd like to show that that measurement is possible. But then the question is, how do we measure it? And I don't think we have we have, there's CAPS, there's some providers or health insurers are using the single item screener to at least identify, do you start to find that people are reporting that they are getting more information from their providers, that they aren't having as much difficulty with the materials that they're getting, and you've seen over time that some of these things have changed. And I apologize for some of I think we probably have different Microsoft versions of PowerPoint, but what can be gathered by electronic health records also? Is there stuff that's already available right now? And this is a challenge, again, for our healthcare system, that we like to think we're progressive, but maybe in some ways we're not, because we're trying to get the argument for the business case to look at this stuff, to start thinking, how do we perceive quality in some of these aspects? And you do see resistance from the hospital management, and again, it's making that sell that business case. And then finally, interventions must target improving access to understandable, actionable health information. And if that's really where we focus it, that we think of this at least as that the intervention is not to jump automatically to improving clinical outcomes and behavior change even, but that at the very least we're trying to focus on what we view as a health literacy metric. Can we think about, one, how health literacy standards apply to everybody? That this is a patient-centered approach, right? That you want to be able to create communications that are diverse for a large audience, a very diverse audience, but then thinking of cultural competency principles and also language access. But again, what is a sufficient business case? Because a lot of this, to say that you need to translate materials, to say that you want to apply, that you want to revamp a large amount of written communications or redesigning a website to make sure that it's more accessible or reaching people the way they want to be reached, that does come with some at least acute investment. And that, I think, is the story that we hopefully will explore more. And I'll end with that right now.